Hello, I'm Jim Conley. I'm an attending physician at CS Mott Children's Hospital, and today I would like to speak about the therapy for severe combined immunodeficiency, or SCID, in particular the use of bone marrow transplantation for this disorder. Severe combined immunodeficiency is really a heterogeneous group of disorders which do have in common deficient T cell function as well as B cell function. There are multiple subtypes of SCID, which are often defined by the presence of B cells, although these B cells are typically non-functional, as well as the absence or presence of NK cells. There are also some subtypes, which are referred to as leaky SCIDs, which would include disorders such as Omenn syndrome, which are not considered to have significant T cell depression. They often do have some T cell activity, but not enough to prevent them from long-term infections. And often the mutations that are involved in leaky SCIDs can be similar to what we consider called classical SCIDs, but they're often hypomorphic mutations, meaning that there is some protein function but not enough for them to maintain normal T cell development. As I said, there are multiple mutations that can lead to a diagnosis of SCID, and these can be inherited in both autosomal dominant recessive as well as X-linked inheritance. As Dr. Walkovich mentioned, the typical presentation is that newborns are quite well when they're born, but they quickly succumb to recurrent and persistent infections, particularly within the respiratory and GI tracts. They also can develop atypical infections, including fungal infections. This is typically, in the past, has been how patients have presented to our department with frequent and unexplained infections. The diagnosis is through specific analysis of subtypes of lymphocytes through flow cytometry to identify the absence of T cells. Before modern therapy, this was a universally mortal disease with patients not surviving past 2 years of life. The treatment options for SCID would include supportive care, meaning that they would have limited exposure to infections, which would include cessation of breastfeeding from mothers, as well as antimicrobial prophylaxis. And recently, there have been other options that have been used for SCID patients, including the introduction of gene insertion therapy through retroviral technology. This has been done on a limited basis and is not considered a clinical standard of care. The main complication being from this is the development of leukemia, since the insertion of these genes are quite random. And in fact, when this was used in a X-linked form of SCID known as common gamma chain SCID, these patients had high incidence of leukemia, with 4 of 9 patients developing this disorder. There's also, in certain cases, such as adenosine deaminase deficiency, you can have enzyme replacement. Although this does restore some T cell function, the recovery is quite variable and tends to wane over time. So the only proven cure, and one that is considered the standard of care for severe combined immunodeficiency, is through a hematopoietic stem cell transplant. The stem cell transplant process that's used for SCID is quite unique. So before reviewing the transplant process for SCID, I would like to review some basics of transplant so you can really understand the true uniqueness of using transplant for SCID. So initially, in patients who have normal immune systems, the patient or recipient has a packed marrow which is full of hematopoietic stem cells, as well as competent immune cells, and the ones that are important in stem cell transplant as far as graft acceptance or rejection are T cells and a type of lymphocyte called natural killer NK cells. In the stem cell process, if one were to infuse stem cells alone without any prior conditioning, the cells would be infused into the patient. However, there are 2 barriers for the stem cell transfusion to actually be successful. So one, in a competent immune system, there will be immune-mediated attack through T cells and natural killer cells upon the stem cell product. In addition, stem cells will try to engraft within the bone marrow. However, if the bone marrow is full of recipient hematopoietic stem cells, they essentially will not be able to find space to grow and replicate. And so without prior therapy, between actions of the recipient immune system and without basically not having any space in the marrow, is that these cells will eventually die off and not be successful. So to avoid these issues, of course, the typical transplant in patients with competent immune system is to employ conditioning chemotherapy. Conditioning chemotherapy does have actually 3 roles. One of the roles, of course, would be anti-cancer therapy, which would not be important for patients with a SCID diagnosis. But the conditioning chemotherapy plays 2 other roles. One is to suppress the recipient's own immune system, so they will not go further and reject potential later stem cells from the donor. The other role of the conditioning chemotherapy is actually to make some space in the bone marrow, meaning that in order for bone marrow cells to engraft, they actually do need space to grow. Through this process, the immune system is eliminated and the marrow is empty. This is often referred to as a myeloablative chemotherapy, or full intensity, meaning that if nothing is done following conditioning chemotherapy, the marrow will remain empty and not recover, and the patient will eventually die. However, with infusion of stem cells following conditioning chemotherapy, there's no longer an immune system available to attack the new stem cells, and there's plenty of space within the bone marrow for these new stem cells to grow. Over time, which can take weeks to months, is that you'll have further growth within the bone marrow of hematopoietic stem cells and eventually development of a full competent immune system, which consists of not only donor T cells and natural killer cells, but of course other cells of the innate system, including myeloid cells, as well as other cells of the adaptive system, such as B cells. So this is what would be considered our typical approach for patients and pediatric patients for the majority of cases of bone marrow transplantation, particularly in the category of transplanting for malignancies. However, for patients who have severe combined immune deficiency, they present a unique aspect since they have variable immune systems coming into transplant. So patients with severe combined immune deficiencies are known to have virtually absent T cell function. In addition, there are subsets of severe combined immune deficiency where there is no NK cell function, meaning that the typical cells which are involved with graft rejection, T cells and natural killer cells, may be absent within the host. Therefore, it is possible and has been done is that these patients can actually have successful transplantation without conditioning chemotherapy. These patients get infusion of stem cells, and with the stem cells, of course, they get mature cells of the immune system from the donor, which would include mature T cells and natural killer cells. These cells of the donor, the T cells and natural killer cells, can actually perform an immune-mediated attack on the recipient's marrow and actually, through this process, create space, meaning that this wasn't chemotherapy that caused space in the marrow, but it's actually through immune-mediated destruction of recipient marrow cells. By creating space, the donor stem cells are able to engraft and have space for them to grow and develop. The difficulty in this is that although you can get engraftment of cells, is that there is variability in how well you actually engraft. It would not be an uncommon situation for the recipient hematopoietic stem cells to still survive this process, again because they were not eliminated with myeloablative chemotherapy. In this process, often you'll get recovery of T cell function, but it is often the case that you may get poor development of other aspects of the immune system, including natural killer cells, myeloid cells, and B cells. Now, of course, you would still have recipient cells remaining, and so therefore myeloid cells such as neutrophils and monocytes may still remain, but they may actually be of recipient origin, while the T cell immunity is monitored by the donor stem cell source. B cells, however, may not develop in either case, and therefore some of these patients who do not develop their B cell immunity will require lifelong IVIG therapy. This approach has been tried and been successful, but because of the complications of having both donor and recipient stem cells remaining, as well as the possibility of not gaining humoral immunity, it is questionable whether this is the best approach for these patients. So what would be the advantage of not using conditioning for severe combined immunodeficiency? Well, the main answer is that, of course, this is toxic medications that these patients are receiving. And of course, given the early presentation of these patients, they're often receiving them within the first year of life. Therefore, they would be at risk for significant toxicities. It's felt that there are a lot of organs, particularly the brain, that are going to be more susceptible to toxicities for chemotherapy. However, by avoiding the chemotherapy in using matched sibling donor transplant, the success is quite successful, with survival rates up to 90 to 100%. The downsides from these positives is that often the rate of graft rejection can be higher in these patient populations, once again because they did not have significant chemotherapy beforehand to make space in the marrow or to eliminate the recipient immune system. So some of them require what are called booster transplants, which means they need to get a second infusion of stem cells. The other, as we had already discussed, is that although you can get restoration of T cell function, if that patient is lacking other aspects of the immune system, such as B cell function, this may not recover. In this slide right here, this was looking at overall B cell function in a paper published by Haddad in 1998, which showed that the recovery of patients' B cell function following transplant without chemotherapy is quite variable. In the upper panel, in panel A, you can see that all patients over time do develop good T cell engraftment. However, if you look at the lower panel, they do not all recover sufficient B cell function. This, although can be replaced with IVIG therapy, once again, this is a lifelong requirement. So should we do conditioning therapy in patients with severe combined immunodeficiency? So by using chemotherapy prior to transplant, we would provide immune suppression and as well as make space within the marrow, which would increase the chance of not only engrafting the cells and limiting the amount of booster transplants, but also increase the chance of getting full recovery of the immune system, meaning both T and B cells. However, the downside would be both short-term and not only that, long-term complications and toxicities that are associated with chemotherapy. So to help kind of combine these two approaches is that what is commonly done now is the use of what's called a reduced intensity transplant. So what does that mean? So if we look at, again, a patient with severe combined immunodeficiency, instead of giving intense chemotherapy, they get less intense chemotherapy, what should we refer to as reduced intensity. Not only is it's not just smaller doses of chemotherapy, but it's actually different agents. Typically these agents, instead of being toxic to the marrow, they often have stronger immunosuppressive therapies. In this case, with reduced intensity, what the function of them will be is they will have complete suppression of the immune system. However, they typically do not fully ablate the marrow, meaning that after the therapy is that there are still recipient hematopoietic stem cells present. However, by creating this small amount of space and by eliminating the recipient immune system, is that you can get some of these cells to engraft within the marrow. As the donor immune system starts to take hold, both T cells and natural killer cells from the donor can actually therefore make further space within the marrow by an immune-mediated attack. So similar to our first slides where we talked about the recipient immune system attacking the donor can do the same thing to allow itself to further grow within the marrow. Over time, the recipient hematopoietic stem cell compartment can be eliminated by the donor immune system, allowing for further growth of the donor immune system and eventually replacement of the marrow, as well as full constitution of the immune system. So unlike using a myeloablative chemotherapy regimen, which would increase their toxicities, we basically rely upon the donor immune system to fully cause restoration of full donor involvement of the marrow, as well as full donor immune system development. So this seems to be the best of both situations that will allow us to transplant these patients more safely. And as has been shown, patients who do get reduced intensity therapy tend to have an increased overall survival. As you can see in this graph here, in a paper published by Rao, is that patients who got reduced intensity conditioning had better overall survival, and in addition, as previously mentioned, have decreased need for long-term IVIG therapy, as well as decreased necessity for requiring booster transplants. Now that we talked about conditioning chemotherapy, another important question is donor source for these patients. So of course the preferred donor source, like for the majority of transplant, would be a matched sibling donor. However, a full sibling only has 25% chance of being a match. And in addition, since this is a genetic disease, we also have to factor that into the chances of the sibling having the disease. When both of those factors are taken into account, 90% of patients will not have a matched sibling donor. What has been tried in the past has been a haploidentical parent donor, meaning that they only match half of the HLA antigens from their child. And the reason this has been done in the past is it allows a readily available stem cell source. The difficulty with this is that because of the mismatch, there's a high risk of the donor or maternal or paternal T cells to attack the patient's body in a process known as graft versus host disease. And therefore, because of that, they have to go a rigorous process, including trying to remove T cells from the donor source. Despite the complication, the overall survival is relatively good at overall 75%. More recently, people have used matched unrelated donors as well as umbilical cords, and both of these have been successful with survival rates increasing up to the 80% range for both of them. A matched unrelated donor has shown reduced graft rejection and improved immune reconstitution. Umbilical cords have similarly shown other advantages, particularly reduced time for attaining the stem cell source. So why is obtaining a transplant so quickly important, which comes into very importance with the recent initiative by the state of Michigan to screen all newborns for severe T cell deficiencies. So one is infectious exposures. We do know that patients that have had significant infectious exposure, particularly that have active infections going into transplant, have a high rate of mortality, around 75%. What is also known is that for thymic to development to occur is that they actually need T cell engraftment of the thymus for it to fully develop. When people have looked at autopsy specimens of patients with severe combined immunodeficiency, the thymus is equivalent to about a 12-week-old in utero patient, meaning that the thymus develops, but you don't start seeing T cells in the fetus until they're about 12 weeks of age. And therefore, since none of these patients have had T cells, their thymus is essentially equivalent to a fetal 12-week-old thymus. If they do not get significant T cell engraftment early on in life, they tend to have poor thymic function later on. If you look at this slide in panel A, it's comparing what are called TREX, which, as Dr. Walkovich mentioned, this is how we're screening for newborns for T cell deficiencies, which is a marker of thymic T cell development. For patients who received early transplant, meaning less than 1 month of age, they have more robust TREC development. In panel B, what they're all similarly looking at is that they're looking at T cell counts, and these also do improve with transplantation. When people have looked at long-term effects, not only survival but also long-term effects, they do have shown that the improvement has been in patients who do receive transplant less than 1 month of age. When the investigators have looked at the overall transplant process, patients that are transplanted less than 3.5 months of age have significant improved survival, roughly a 90% survival as compared to a little over 70%. In addition, other long-term complications, which would include requirement of booster transplant as well as failure to thrive, is improved in patients who have been transplanted at a very early age. So that concludes kind of a summary of what is known about how a transplant is for severe combined immunodeficiency, which leads me to what we're currently doing here at the University of Michigan. So at the University of Michigan, we feel that we are able to provide expert clinical care in the care for patients with severe combined immunodeficiency. So being the largest transplant center at the university in the state of Michigan, we have experience in transplanting patients with SCID as well as other primary immune deficiencies using reduced intensity conditioning. We have been an active player in the development of the newborn screening program here at the University of Michigan. As part of this process, we have prepared and submitted clinical practice guidelines to the state of Michigan to use as a model for treating these patients with SCID. We've also developed a unique immunohematology clinic, which is not only unique in the state of Michigan, but in the United States, which brings in multiple specialties, including immunology, hematology, oncology, bone marrow transplant, genetics, and infectious disease, bringing the experts which are truly necessary to come together to best treat patients with primary immune deficiencies. We're also developing both pathological and genetic screens to quickly diagnose these patients so they can get the care they need in a rapid fashion. We also consider that we also have expert research in these areas. We are an active member of the primary immunodeficiency treatment consortium, and we have studies that are open which are looking at patients who have been transplanted for SCID in the past, as well as looking prospectively at these patients. We are developing protocols not only for the treatment of patients with SCID, but in particular we are interested in looking at any long-term effects these patients may develop, including their effects on growth, and particularly looking at neurocognitive development. We, of course, have great collaboration with multiple bench-based research and looking into developing screens and tests to really look at these patients and how to better understand not only the diagnosis, but the pathophysiology and the treatment of these immune deficiencies. So in summary, stem cell transplant is really the only well-established cure for severe combined immunodeficiency. As previously mentioned, the ideal donor source for these patients is a matched sibling donor, but these are typically unavailable. The current approaches to transplant does involve, in certain cases, using no conditioning, particularly for patients with a matched sibling donor. However, in cases where there are increased risks of graft rejection, meaning that the match is not as robust as a matched sibling, we are often using reduced intensity conditioning for alternative donor sources. The overall outcome for treatment for SCID using bone marrow transplant is excellent, and we continue to make strides in the improvement of the treatment, which include better understanding of SCID as well as transplant-related issues such as reductions in graft versus host disease and other supportive care measurements. And finally, as it relates to newborn screening, of course, would be to earlier to transplant these patients, the better, meaning that not only do they have improved short-term survival, but also have less overall long-term toxicities and have more robust thymic development.